Okay, so I'm back for chapter 44, antihypertensives. So hypertension, the definition is systolic greater than 140 and a diastolic greater than 90. So, you know, your systolic blood pressure is what is supplying the blood to the body, and your diastolic blood pressure is what's supplying the blood, is what is supplying the heart. So that's kind of how you know how much pressure is being pressed against the vessels. Going out to the body is systolic, and being pressed to give to the heart is the diastolic. Docs tend to worry a little bit more about diastolic versus systolic if, you know, especially if you have a heart patient or something like that. So it's just important to know which ones that the systolic sustains the body, the diastolic sustains the heart. Essential hypertension is most common, the most common type, 90% of people. The exact origin is unknown, but you have your contributing factors underneath: family history, hyperlipidemia, diabetes, aging. You can see these different things on here are all part of that. Most of these all are things that are damaging vessels and then narrowing them. So remember, we kind of talked about that the other day with excessive sugar will damage the vessels and then cause plaques. While in this situation, many of these things cause the plaque buildup to go around, so the blood has a more narrow vessel to be the blood shooting through to get to either the body or the heart. 10% of hypertension is related to renal or endocrine disorders. Kidneys and blood vessels regulate, maintain blood pressure, so via controlling fluid volume and the renin-angiotensin aldosterone system, and kidney controls sodium and water elimination retention, affects cardiac output and systemic arterial pressure. So think about this for a second. Affecting cardiac output. If everything's backing up because I'm not able to sustain, that actually ends up backing up all that systemic fluid, and a person ends up with CHF because that's essentially a backup. So all these things end up like going right together, but it takes a long time to put them all together. Anyway. So here you go. This is something that I do again. I believe is it next term that I do this? No, maybe not. Okay, so if you look at this, hypertension, selected regulators of blood pressure, kidneys via renin-angiotensin system. So look at the top up here. You have the renin, which is in the kidney, and the angiotensin, which is from the liver. So angiotensin 1 is secreted from the liver and the liver and kidneys, and then you. So I'm sorry, those are together. Anyway, we're gonna keep moving. You see the plus sign up there? That's what that is. Okay, so angiotensin 1. This is a weak vasoconstrictor. So if I've got a weak vasoconstrictor, then I'm going to come over here, and as you see, angiotensin converting enzyme then comes in here to combine with angiotensin 1, and then it creates angiotensin 2, a potent vasoconstrictor. So that's going to end up coming over here and causing peripheral vasoconstriction and then increased blood pressure. Over here, it's going to cause aldosterone to release, and which then comes down in I'm sorry, I'm tripping over my tongue. So it's going to cause sodium retention because aldosterone causes sodium retention, and so that's also going to increase the blood pressure, but it's also going to bring in water, right, because sodium wants the water, and it's going to restore the fluids. So a lot of times with our meds, and we're going to talk about these ACE inhibitors, will stop either here the conversion or here some kind of conversion, so they don't end up having all the rest of these things that happen typically in the body, making it so they have decreased blood pressure. So we have baroreceptors in the aorta and the carotid sinus. These things are the ones that are regulating the blood pressure, okay? So your baroreceptors in the aorta take on and they regulate what's going on with that. Then the vasomotor center in the medulla, so in our brain. So you can kind of read through this. You notice down here this antidiuretic hormone. This is a hormone that's produced by the hypothalamus and stored and released by the posterior pituitary gland. It says ADH stimulates kidneys to conserve H2O deficits. If fluid overload, ADH blocked ADH blocked and kidneys excrete more water, and a person can actually die when they have some kind of dysregulation with the antidiuretic hormone, because if they excrete way too much water and we can't keep up. So it's pretty rare, but there is conditions for that. So physiological risks, so excessive intake of saturated fat and simple carbohydrates, alcohol, which increases renin secretions. So, you know, anything that's going to cause that buildup in the vessels really is some kind of a risk factor. You have cultural issues or cultural responses to antihypertensive agents. So, so for African Americans, beta blockers and ACE inhibitors are less effective unless given with a diuretic. So it's interesting to learn these things because we know then if somebody that is either African American or you can see below Asian American, that we have to sometimes check on culture to see how effective the medication will be for the person. So hypertension in older adults, orthostatic hypotension is a big issue. So the orthostatic, hopefully you guys have learned, is when the person stands up, they have a big blood pressure drop. Some of you have probably experienced that a time or two where you've stood up too fast, got dizzy, sat back down, seen a bunch of stars. It's because your body had a quick blood pressure drop. Your body didn't keep up or maintain where it needed to be. Well, older adults have an even harder time with this because, you know, everything's slowing down on them. So we actually end up doing a lot of orthostatic blood pressures on patients that are elderly. So non-pharmacologic things that that we can do to reduce hypertension is stress reduction techniques, exercise, salt restriction, decreased alcohol, and stopping smoking. So all of those things can help with hypertension and actually end up making it so people don't have to take their meds anymore. Eventually they can get back off those. Sometimes that's how it is with diabetes type 2 as well. So here you go, you've got guidelines for determining. So right now they're still saying that 120, less than 120 and less than 80 is normal. But pre-hypertension, notice if you are 120 to 80, it's called pre-hypertension. These are going to be numbers that you're definitely going to need to know, okay? So make sure you circle and highlight. You need to know the different types, the normal, the pre-hypertension, stage 1 hypertension, stage 2 hypertension, okay? Look down here for your diastolic pressure, 100 or more. And when people are in that range, you know, it's time to get a little bit nervous because those patients, their heart has got way too much pressure being put on it. So you've got different categories, diuretics, which we just talked about, sympatholytics, direct acting, ACE inhibitors, angiotensin II receptor blockers, and calcium channel blockers. So diuretics, we have already talked about most of this stuff. You'll be able to include this in with your drug cards. Right here you can see chapter 43, so we're going to just move right on through this. Your sympatholytics, so sympathetic depressants, and you're going to notice, you're going to see things that we just learned about. Look at that, beta adrenergic blockers are beta blockers, and then look, you got alpha adrenergic blockers, all the things that we did. So remember, as long as you're keeping straight your sympathetic and your parasympathetic nervous system, you'll be able to know how things are working. So your beta blockers, as you know, is one of the big ones that you're definitely going to be using. I've got a lot of information on here for you for those. You know, you want to look at the bottom here. Do not use in 2nd or 3rd degree AV block or sinus bradycardia. You know that with the bradycardia that we definitely don't give that because it's blocking and reducing the heart rate. So you want to make sure that you don't do that. And again, beta blockers for COPD patients. We kind of talked about that a little bit too with some of the patients that with the lower respiratory disorders may be contraindicated to use beta blockers. So make sure you just read through this, add some stuff to your cards as you need them. So you have non-selective, so your propranolol is on there, and your Coreg. Coreg is also used as a contractility med for the heart, which we'll eventually get to that. There's your contraindications, and then you've got your list down there. Look at there, you've got your metoprolol or metoprolol that we're going to be seeing and using a ton of. And so you want to make sure that you, you know, have all this information put in your drug cards that you need. Here's some more stuff for you. Go ahead and just read through that. You should probably have a lot of this already if you've already made it. Look here, nursing interventions. We want to teach them not to stop taking it abruptly because of rebound hypertension. So then we have your sympath, or more. You have the alpha-2 agonist, so methyl-dopa, clonidine. Remember, clonidine is catapress. We've been talking a lot about that. So it's a decreased sympathetic response from brainstem to peripheral vessels. This again is going to kind of lay this out for you that you're with your action contraindications. Sorry, my kids are having a bonfire right now and they're cracking up over there. Diuretics are frequently prescribed to avoid fluid retention. And then look again at the bottom, avoid abrupt stopping because of rebound hypertension. So you're going to include this all in all of those. You may have to change a few things for just the drugs themselves, but you know, you can put those in. You can put those in the parentheses, like we've talked about before. We're going to keep actually going through the rest of this here because we've kind of already talked about this. I don't see a lot of these. Labetalol actually is one, though, that is used in the ICU a lot. It's a much stronger, more potent beta blocker that we give to patients that are not responding well to anything else. So you have direct acting arterial vasodilators. These are very potent. They relax the smooth muscles of the blood vessels, mainly the arteries, causing vasodilation. You can go ahead and read through these for your things. There's not anything extra that I want to add to those. You have angiotensin-converting enzymes, so the ACE inhibitors. These are the big one that I was kind of just going through with. They inhibit the formation of angiotensin 2, which is that vasoconstrictor, and blocks the release of aldosterone, which is the one that promotes the sodium retention. So if I'm blocking that stuff, I'm going to actually decrease the heart or the blood pressure, right? So you can see the list of medications under here. It's important to just really know that there's a blocking happening. There's a blocking happening in the angiotensin system that is, or in when the that's why it's called an ACE inhibitor, because it's going to block or stop the conversion. There you got some more stuff right in there that you want to do. Look down there under contraindications. Potassium-sparing diuretics such as spirolactone, or also known as aldactone. There's a risk for hyperkalemia, so we want to make sure that we don't let them do that. And salt substitutes that contain potassium. So again, we have another angiotensin 2 receptor blockers, similar to ACE inhibitors, prevent release of aldosterone, act on the renin-angiotensin-aldosterone system. I'm not going to go in depth on this stuff. It's just going to be more about the conversion and things like that. You have your direct renin inhibitor, so I'm not actually going to be asking you anything on that. Calcium channel blockers, this is another big one that you guys are going to see. So the actions decreasing calcium levels and promote vasodilation. So free calcium increases muscle contractility, peripheral resistance, and BP. Thus, if decrease, is going to lower the blood pressure. So you have your meds here. This right here is your cardizem, your diltiazem. I use that a lot actually, so you have some side effects that you can list right here, and that is it. Sorry, I kind of had to rush through that last one here because I saw I was getting close. If you have any questions, let me know. Again, we can talk about this when we see each other a little bit more, but I'm not going to go super in depth. You do need to have these drug cards made though, because especially with your calcium channel blockers, your ACE inhibitors, your beta blockers, which you should already have done, these different antihypertensives, and you'll be already working on the diuretics that also work for hypertension because we just did the diuretics. So it's going to be more of our basic stuff and only things from our discussion here. So if you listen to this a couple of times, you'll be straight for what you need to know, and make sure you study your slides. I will see you guys on Monday.